So good morning, dear audience, dear colleagues. In the next few minutes, I kindly present to you the future biomarkers of preeclampsia. So about me, I'm David. I'm a first-year PhD student and third-year OBGYN resident. And together with my great supervisors, we have the vision to reduce maternal and fetal morbidity and mortality. And our mission is to provide proper and early diagnosis and treatment for severe preeclampsia. In order to achieve that, we have two specific goals. As you can see, both of them are concerning preeclampsia in pregnant women, and we started them this year, autumn. I will go into further details later on. So about preeclampsia, it's a very important pregnancy complication affecting almost 5% of pregnancies worldwide, and it causes almost 500,000 fetal and 70,000 maternal deaths worldwide. So mainly for the definition, we need some form of hypertension values and end organ damage, either in the maternal or the fetal components. Clinically, we can differ between mild and severe preeclamptic forms. Of course, the severe has higher hypertensive values and more prominent end organ damage. And of course, it means more complications. To this day, we have no available predictive value for severity, but they would mean a different follow-up, a different hospitalization rate, and of course, the most important, different pregnancy outcome. So our first goal is to investigate the association between microRNA 210 levels and the severity of preeclampsia in pregnant women. So about these microRNA 210, first of all, I have to say that the pathogenesis of preeclampsia is still relatively unknown. We know that some form of malperfusion, hypoxia, and oxidative stress is present, and this microRNA is a single-stranded RNA, which is hypoxia-induced. From these 210 variant has the most evidence and potential, and their levels can be measured mostly with real-time PCR. And these articles usually present their values in a fold change value. This is a division between the preeclamptic and the control values of these microRNAs. We already know that these microRNAs contribute to the pathogenesis in some form. We don't know exactly how to the pathogenesis of preeclampsia, and elevated level could also associate with the severity of preeclampsia, and our aim was to investigate this association. So we used the PECO framework where everyone was, of course, pregnant women, and we compared the mild, severe, and control healthy preeclamptic patients, of course, with the healthy controls, and our outcome was plasma or serum microRNA 210 levels, and our hypothesis was that elevated levels are associated with the severity of preeclampsia. So we conducted our research on the 21st of November in 5 databases, and we found almost 800 articles. After the duplication removal and the selections, we included 7 eligible articles in the meta-analysis and 2 articles only in the systematic review. In this figure, I kindly show you our main results. The association between microRNA 210 levels and the severity of preeclampsia. So our outcome parameter is, of course, microRNA 210 values, which could be the new biomarkers for preeclampsia. These are measured in fold changes. Mainly, we can see fold increases. These are ratios between the preeclamptic and the control population. In these studies, so the studies that we included were all case control studies. We had 7 in the mild and 6 in the severe group. Altogether, we had 100 mild, 100 severe, and 200 preeclamptic, and 200 healthy patient as population. And as you can see, the heterogeneity between studies were very high. It could be due to the methodological differences between the studies. At the end, we got the result that in the mild population, we have a 3.12 fold change increase, and in the severe group, a 5.82 fold increase. It means that these values are 3 and 5 times higher in the preeclamptic population. In the end, we couldn't find any mathematical significant differences between the subgroups, but we can tell that the microRNA 210 values are strongly associated with the preeclampsia, and there is some form of association between the severity of the disease and these microRNA values. But of course, more prospective studies are needed in the future. So for our risk of bias assessment, we use the GBI checklist for case control studies, and according to this, we could include all our studies in the meta-analysis. Here you can see our progress of the first project. We are currently at the manuscript writing phase. So our strength is a rigorous and precise methodology, and we have, I will mention it soon, important future research implication, but the limitations are the small sample sizes and that we only could include case control studies. So our main conclusion is that there's a strong association between the elevated microRNA 210 levels and preeclampsia in pregnancy. At this stage, we couldn't find any current, so we cannot tell any current practical implications, but we have very important research implication for the future. So there is a very, very high need for the development of standardized microRNA assessment methods, and we could use these microRNA 210 levels in the future in early pregnancy to get a predictive value. Of course, for this we need more prospective studies, or we could use it as a prognostic marker at the time of the preeclampsia diagnosis. Right now, our manuscript status, we are finished with the result section, and we are planning to submit our article during May, hopefully. In the second project, we would like to investigate free fatty acid levels as protective or risk factors for preeclampsia in pregnant women. As I already mentioned, the exact pathogenesis of preeclampsia is still unknown. There is some form of oxidative stress, and lipid peroxides at the end will be elevated, and free fatty acid levels will differ. That will cause, in the end, endothelial dysfunction. It's important to mention that other lipid parameters were already investigated, and they found that prospective studies are needed for to be included in order to include them in the future clinical risk assessment tool. So there are two forms of free fatty acids. There are saturated and unsaturated ones. The saturated are the pro-inflammatory, which can cause, in the end, placental ischemia. And the unsaturated ones are in the abbreviation form PUFA and MUFA. They are anti-inflammatory ones, and they could reduce the risk of preeclampsia. The role of these are still relatively unknown, but we can tell that they are contributing to the pathogenesis of preeclampsia, and the elevated or decreased levels of these certain free fatty acid levels could serve as a protective or risk factor for preeclampsia. And they could be included potentially in the new, in a newer version of the preeclampsia risk assessment tool, or they could be used in the future for potential risk-reducing supplementation. So we also use the PECO framework for our clinical question that do different plasma or serum free fatty acid levels serve as a protective or risk factors for preeclampsia in pregnant women, and we will compare preeclamptic patients with healthy patients, and the outcome will be plasma serum free fatty acid levels. And as I already mentioned, the clinical and research implication could be that they could be included in the new risk assessment tool, and we could get potential new supplementation targets. Our preliminary research key contains two domains, the population and the factor, and we plan to conduct it in 3 databases, and altogether in the preliminary research we found almost 4,000 articles. In the end, we have 2 specific projects. Both of them are concerning preeclampsia in pregnancy, and we wish to finish these projects and make them come true within 2025. And I would like to end my presentation with Abraham Lincoln's word: the best way to predict the future is to create it. Thank you for your kind attention.
like to ask, how does the microRNA can be a predictive value?
Yes, so in the long run, if research groups will do prospective cohort studies, they can start the microRNA assessment in the early pregnancy before the diagnosis of preeclampsia, and they can follow up the patient and see the different elevated levels, and with this they can get a predictive value for the future. It will be done by other research groups or us, hopefully.
Thank you for your presentation. You said that that there's a need for standardized management of microRNA.
Yes.
In your article, will you be able to say that standardized treatment for the microRNA?
With my supervisors, we plan to give some methodological advices in the discussion. So mainly, there are three big components in the assessment that can cause the big heterogeneity. Mainly the assessment tool. It's not always real-time PCR, the normalization ratios and the values of the microRNAs, and at the end, the statistical analysis of these techniques. So we will try to give some form of standardized way to doing it, but of course some future studies are needed to really say that in the end.
Thank you.
Congratulations, it was a really wonderful presentation. I'm from a dentistry group, so it was basically really interesting for me. And I was wondering about your first project. What were the main strengths of the study? Because could you be more specific? What was the
main strength?
Yes.
We wrote rigorous and precise methodology and important future research implications. These two maybe.
Okay, thank you. And one more question: is there any clinical relevant, or is there any connection to the dentist or the oral lesions or oral health to this microRNA, or do you know anything about it? Or
so in the future there can be many clinical implications. Right now with these values there is no possible way right now to say a real clinical relevance. More research is needed. This field is very new. They just received the Medical Nobel Prize for the discovery of microRNAs this year. So it's a brand new field and it's developing right now. And in case of dentistry, sorry, I have no idea. I have no idea about teeth. It's my blind spot as a gynecologist. We can say.
We can work together. Thank you very much, David.
Thank you.
Any more questions? I would like to also have a question. That you said that you do this test early pregnancy. What does it mean exactly? Until when?
So in the first trimester, it would be the best, yes.
And is there any studies, or is there any, if the patient start to take acetylic salicylic acid, then it's changing the microRNA levels, or like if you have this high level, then is it ethical to not to give this? How you are gonna proceed with that? Because
yeah, it's a very good question. No, there are no studies yet. We only have one study included where they measured the levels in the first trimester, and they didn't include any aspirin protection. So it could be a great future predictive marker. Maybe if it's that this microRNA level is higher, then we can administer aspirin, of course. But right now we have no data about that.
Okay, thank you. Thank you very much for the great presentation.
Thank you.
Just one fast remark at the end. Congrats. I would like to highlight that he used the term association really well in this topic. So no causal relationship can be done here. And I would just like to have one more remark, that did you ask your stat guy that would you be able to do within study comparisons of the fold changes? Because I was really disappointed that although there is a obvious effect of the severe and the mild preeclampsia, it was not significant. But if you could do it within study, I was checking the studies, then maybe somehow you could twist a bit on these results.
So the problem is that we have one very outlier study. You can see it below. It has 10-fold increase in the mild and 19 in the severe one.
Yeah, but if you compare it, it's just twofold. If you compare the Zhang, it's 2.5-fold, so 10 to 3.5. It's almost the same as 20 to 10. So if it would be within study, these differences would be smaller because maybe they measured something differently, but the rate that they observed is the same as with the other.
Thank you. It's a very good idea.
Ask your stat guy.
And we also asked about this. So we also asked the statistical colleague Mikolt about this, and she said that of course you can write it in the discussion, and I will. I've already wrote it, and also in the result part that these ratios between the mild and severe is around 2 or 3. So we can write it down, but there is no reason to do a plot about it because it's just a number, and we can present it in the description of the article.
Yeah, but that's the number that you are looking for, that it's twofold higher in severe risk, right?
Yes, but
that's what you want to prove.
Yes, but we cannot really compare them like this because the control population is almost the same in the two subgroups.
Ask Tamás Kóé. I don't know who your statistician, but he did models for me within study, so there are statistical ways of doing it.
Thank you very much. Thank you.